Now, let's take you through, quickly again, how cholesterol is formed and where it goes. If we look here, free cholesterol, cholesterol esters, really come up from adipose tissues. They occur in the liver. If we look then, the liver then secretes that in form of VLDL, which is very high in triglycerides and low in cholesterol esters. That VLDL can go on to be deposited as free fatty acid into adipose and other tissues. But what happens, as the degree of triglyceride shrinks and the LDL molecule gets smaller, it forms LDL. And the LDL itself is the portion that is responsible for atherogenesis. This is the type, LDL, that goes into the cell in the peripheral tissue, such as the linings of arteries, of the carotids, the coronaries, peripheral vascular, that actually, in fact, causes the atherogenesis or atherosclerosis. So we have a situation here where the LDL that was coming from the liver, secreted by the liver, now enters the cell, the peripheral cell, and begins the process of atherosclerosis. Where HDL comes in is with LCAT, it actually removes the free cholesterol and cholesterol ester from the cell itself, and this is what is called the reverse cholesterol transport. It takes the HDL and brings it back to the liver. So it is responsible, the reverse cholesterol transport of HDL is responsible for removing the bad cholesterol, or the cholesterol which we call LDL, from the liver, from the cells back into the liver. Now, unlike LDL, which carries primarily cholesterol from the liver to the peripheral, HDL functions primarily in the reverse cholesterol transport. And that's really where we're discussing here today. HDL delivers cholesterol to stereogenic tissue, such as the adrenals, ovaries, and testes. So if we look here, this is the macrophage cell, which is laden with LDL cholesterol. It is the HDL that removes the LDL from the macrophage cells, returns it back with the SRB receptor back to the liver, and that in fact also with the VE receptors onto the liver itself. However, the other effect that HDL has is that it promotes hormones. It delivers it to the adrenal glands, the gonads, in order to produce additional hormones. So it has a beneficial effect in an endocrine nature. I wanted to point out to you where we're going. This is metabolic syndrome. Metabolic syndrome, I think we've all seen patients who fit that category. Fortunately, I don't see anybody here in the room that fits this category, so that's good. But the metabolic syndrome has been described in the last 15 years as individuals who are overweight. And they're individuals who have a waist size, men greater than 40 inches, women greater than 35. Everybody's sucking right now. They also have elevated blood pressures. The systolic blood pressure above 130. They have elevated blood sugars above 100. And they have elevated triglycerides above 150. We call these people the elevated syndromes because the other thing that's associated with them is they all have diminished HDL. In men, HDL is less than 40, and in women, HDL is less than 50. So these particular individuals are more prone to cardiovascular disease. Now, what's the therapy that we have for these individuals? What's the therapy that we have out there for reducing cholesterol? Well, weight loss is one of the major ones. Weight loss works by decreasing the LDL, or ApoB, and LDL. So it reduces all the cholesterol esters. Fish oil, very effective, especially with the omega-3 fish oils, by decreasing triglycerides and ApoB, and it increases the clearance of LDL cholesterol. So it predominantly works by decreasing triglycerides, but has an importance in removing LDL cholesterol. Alcohol has been pointed out in modest amount increases HDL, or ApoA. And estrogens increases HDL and ApoA, also in young postmenopausal women. We have PPAR antagonists, such as fenofibrates, such as fibrosol, which has been discussed here, and also trilipids. These all work by increasing HDL and increasing triglycerides. They're primarily responsible for the patient who has a high triglyceride level and low HDL. The statins, and we've talked a lot about statins, decreases LDL ApoB, and the CPEP inhibitors, which was described earlier, our tercepitrib, increases HDL and APO1. But this was developed and in large studies turned out to be detrimental, in that even though it raised HDL by 1/3, we saw that hypertension and heart failure and mortality was much higher. So this was a bust for Pfizer in terms of developing a CPEP inhibitor. But others, anacetrapib and dalcetrapib, are very promising. Niacin has been pointed out, or B3, increases HDL and APO1. And we now have infusions of ApoA1 Milano, which has been described, and reconstitute HDL, which we can start infusing to raise HDL. These are promising new therapies that are out there and possibly in the future. Now, what about vitamin D, HDL, and fat? Because we're beginning to see the association now between the overweight patient, the patient who has excessive amount of weight, and vitamin D levels. We know, for instance, that vitamin D levels are much lower in fatty tissue. But fat tissue is different. There is what we call subcutaneous adipose tissue. That's the fat underneath the skin. And we have visceral adipose tissue. That's the fat that is around our abdominal cavities and around our organs. This one here, the SAT, or subcutaneous fat, does not appear to be related to vitamin D, but we see that the visceral adipose fat has a direct relationship to HDL. So even though HDL is independent of total body fat, we know that HDL levels are directly related to the amount of visceral adipose tissue, especially in postmenopausal women. It appears that vitamin D protects cardiovascular risk by formation of large HDL in these individuals and causing the reverse cholesterol transport. Now, how do we raise HDL? Well, we can raise HDL by exercise, weight loss, eliminate wheat and cornstarch in your diet. If you do that, you can increase your HDL by about 5 milligrams per DL. If you add niacin, anywhere from 1,000 to 3,000 milligrams per day, you can increase it by 10 to 15 milligrams per DL. If you add vitamin D, on the average of 3,000 per day, you can actually increase your HDL to 50 to 70 by increasing the HDL-2B, the better type. Now, a real-life story that has occurred is as follows. JG was a 53-year-old male who had high Lp(a). Lp(a) is an atherogenic form of LDL cholesterol that is very specific and very atherogenic, especially in young people. He took niacin daily, he exercised daily, mostly ate lean meats and vegetables and a fruit diet. He kept accurate blood levels from 2002. Starting with an HDL of 50, it rose to the mid-60s by 2007. By adding 2,000 units of vitamin D in 2007 and 2008, his last blood draw showed that his HDL level was up to 85 milligrams per DL. What did it do for Lp(a)? Nothing. Lp(a) stayed the same. But he was able to increase his HDL and associate the reverse cholesterol transmission. So to summarize it, vitamin D lowers cardiovascular risk by inhibiting inflammation. It's anti-inflammatory. It inhibits vascular smooth muscle, proliferation and calcification. So the plaque that forms does not get a chance to grow and calcify and age. It regulates blood pressure by volume hemostasis, so it has an effect on improving blood pressure, and regulates glucose metabolism through the action of HDL on cholesterol reverse